called to a 40-year-old male who's fallen 6 metres off a roof. Hello, can you hear me? Hello, Peter, there's no response to voice. Any response to pain? Peter, can you hear me? No response to pain. I'm going to check his airway. Look, looks clear to me. Check his breathing. He is breathing, but it appears irregular. Maria, can I please get you to do some vitals?
Yeah, sure.
So we'll do ECG, blood pressure, BGL, heart rate, and a rest rate, please. And report back to me when you've done that. So I'm just going to do a full secondary survey. So starting from the head, kind of feel here. So I can feel a boggy patch at the base of his head at the occiput. It's about 6 centimetres. Continue down, looking for blood on my way, looking for any deformities. Okay. There's my blood. So everything else seems to be okay. So it's just this boggy patch on the back of his head here. And we appear to have a GCS of 5 made up of 2, 2 and 1. So he's extending and posturing, which is 2. He's making incomprehensible sounds, which is another 2. He's not responding, so that makes 5. So what vitals have we got here, Maria?
So he's got a rest rate of 12 and it's irregular. He's got a heart rate of 50. He's got a blood pressure of 160 on 90. His temperature was 37 and his BGL was 7.6.
Okay, thanks for that. Cushing's triad. So it's sounding like we might have a TBI here from the mechanism of injury and because of the triad present there. So he's got bradycardia, hypertension and irregular respirations. Just need to stabilise the neck. So just because of the potential we might need to RSI, we'll be using towels instead of a collar. So Maria, while I support his head here, would you be able to get 2 towels that are rolled up and secure it with tape for me? And once we've finished that, I'll get you to go update comms, request an R50 for RSI backup. And we'll get some extrication as well, so we need a scoop for Okay, his C-spine is now secured, so Maria, I'll get you to go request for that R50 for
Sure.
RSI and come back when that's done.
What about extrication?
Extrication, we have a scoop, please.
Sure.
Yeah. So I'm going to be treating on the TBI section because of the mechanism of injury and the presence of Cushing's triad. So first, I will insert an OPA, so I'll measure that there. Head tilt chin lift. And now we will apply oxygen under the TBI CPGs. And we will set that at 10 litres a minute to oxygenate the brain. Okay.
Just scoop. Com said RSI is on the way. They'll be here in 10 minutes, and RSI officer said to prepare for RSI.
All right. So we're now in the back of the ambulance. Just before we start driving and meeting our R50 en route, I'll just get you to check some drugs for me. So a bag of saline and some morphine, just because he is agitated, so we may need to give him a little bit of morphine just to calm him down.
Alright, sodium chloride 0.9% October 2017.
Sodium chloride 0.9% October 2017. Perfect. Just prepare that for me.
Yep.
Don't need to attach it yet though, as his blood pressure is high at the moment, so we're not requiring any IV fluids.
Awesome, yeah.
And some morphine as well, please.
Morphine 10 mg in 1 ml, expiring October 2017.
Morphine 10 milligrams in 1 ml, expiring 2017. Perfect. Okay, so you can start driving now and we'll meet our R50 en route. So now I'm going to prepare for RSI. So first we need to place some nasal prongs. We're going to leave these unattached to the oxygen. It's just for while the procedure is in place, so they're ready to go as soon as we need them. We're already pre-oxygenating at 10 litres per minute, so that's all good to go. Got all our monitoring in place, so we've got our ECG, we've got our blood pressure and our SpO2. I'm going to prepare capnography, so I'll just let that calibrate on the side, plug that in, so that's all ready to attach to the ETT tube when our R50 is here. Position the monitor so that it's easy to be seen from this position. So we need to gain IV access bilaterally. So for the purpose of this scenario, we've already gained bilateral large bore IV access for the fluid. But again, for a TBI, we need to maintain blood pressure at 120. As he is hypertensive at the moment, we do not need to put that fluid through just yet. So our running line is prepared. We're going to position the patient in a sniffing position in preparation. So to do that, get a towel and gently, without disturbing his C-spine, place that under the head so he's in optimal position for intubation for RSI. I will also place an ETT tube holder underneath his neck. Ensure the suction is present and functioning, which it is. I will have my bag valve mask ready, set with PEEP at 5 in case we need it. Don't need it at the moment though. So that's ready just in case. I'll now take another full set of vitals, which I will pass on to Maria, who will update our RSI backup of the new set of vitals, and I'll now clear the area around the patient to the right of the patient for the intubation gear for when our backup arrives. Okay, so finally I'll just check my checklist to make sure that everything is prepared. If the ICP cannot visualise the cords within 15 seconds or cannot intubate within 30 seconds with laryngoscopy, intubation is deemed to have failed. In this case, manual ventilation should be used. It is important to make sure hyper and hypoventilation is not occurring. Hyperventilation causes hypocapnia and subsequent vasodilation, which increases intracranial pressure, which can lead to secondary brain injury and TBI. Endotracheal intubation should be attempted once more with a bougie, with or without a different blade. I would help the intensive care paramedic with anterior tracheal pressure, backwards, upwards, rightwards pressure, which optimises the axis, maximising oxygenation. If end-tidal CO2 is higher than 5 millimeters of mercury after 2 to 4 breaths post-intubation, management should be continued. If end-tidal CO2 is below 5 millimeters of mercury after 2 to 4 breaths, the tube should be removed and replaced with an LMA or OPA. If ventilation is possible with these adjuncts, continue with basic airway care, and if not, consider cricothyroidotomy.